Over to the next session, that is on the biomechanics of overhead shoulder injury, and then we'll go to the shoulder injury prevention related talks. I request Dr. John Martin to join me on the podium. I request Mr. Deepak Kumar Pradhan to join me on the podium to moderate the session. It's a pleasure always to get my student talking about the favorite topic, and I request Dr. Prashant Pandian to talk on overhead shoulder injury mechanism, a simplified understanding. Keep in mind, it's simplified for everyone to understand in their own perspective. And if you have any doubts, please feel free to ask questions once his talk is over. Thank you.
So, good morning everyone. I am Dr. Prashant Pandian, and I'll be talking about overhead shoulder injury mechanism. As Dr. Sham had already introduced, since we have a mixed crowd here, I'll try to make this talk as simplified as possible. And please do ask us any questions at the end if you have any. So, yes, I think Dr. Munish has made it optimally clear for everyone. So, who's an overhead athlete? So, I'll talk about the injuries, especially in the shoulders, these people endure on. So, overhead athletes place an extreme demand on the shoulder because of the repetitive acceleration and a deceleration movement. Basically, this activity, what they keep doing repeatedly, this puts an abnormal amount of strain on their shoulder, and this is primarily the reason the shoulder joint is the commonly injured joint in this subset of individuals. So, let's see how this happens, and moving on. Take any overhead sport for that sake. We've all seen our favorite players like Virat Kohli, Maria Sharapova, and Rohan Bopanna, Eugene Bouchard, Jwala Gita. They've all injured their shoulders, and they've all lost time on field and off field, and have missed important tournaments because of that. So, how often do these individuals actually injure themselves? Say, a recent study has told that it's about 2.15 per 10,000 athletic exposures. What is that? 10 athletic exposures every single time they keep moving that way. So, every 10,000 times they do this, your injury chances are at least twice. 2 times it can happen during this movement. So, it's that common. So, I'm sure with the physios and coaches and players here, I think you can understand how frequently this can happen. So, what are the injuries which can happen? Dr. Munish has previously talked about the ballistic type of injuries and the repetitive type of injuries. So, broadly categorizing, in medical terms, we call it as acute injuries and chronic injuries. So, what is an acute injury? When something happens rapidly, something like, I think a football coach has talked previously, he was asking about the injury mechanism in a contact sport where the mechanism of injury is violent enough. It can cause an acute injury. Acute injuries, the entire tissue might be damaged immediately. So, a fracture can happen as shown in the picture, where the clavicle bone, which is the collarbone, essentially can fracture, or bones around the shoulder blade can fracture, or the arm bone, which we call the humerus, can fracture. And you can also have acute ligamentous injury, like in this picture, where this is the collarbone. We call this an AC disruption, where the collarbone along with the ligaments around it gets torn up, and it just disrupts from its original position. And you can have a frank shoulder dislocation, which I'm sure all of you might have seen at least once in your lifetime. So, this is a video of our own Rohit Sharma, who recently dislocated his shoulder and reduced it in a filmy style. It's pretty much like our Tupaki Vijay. You just put it on, back into the book, pull it, it just reduces on. Looks like magic. So, let's try to understand how this happens. So, the other injuries is labral tears, lap tears. Yeah, these are basically cuff of tissues, thick tissues which sits onto the bone, which keeps the bone on bone intact inside the joint. So, these can be torn. And you can also have a rotator cuff injury. Rotator cuff is nothing but the anatomy has previously been discussed. These are tissues which surrounds the joint, which keep the shoulder joint stable. So, and the second group of injury is a repetitive or overuse injuries. When a movement keeps happening repetitively, the tissues can get injured with minor incremental overtimes. So, something like an bursitis we call can happen, or a rotator cuff tear can happen, And this picture shows an long of biceps tendon. So this is the biceps tendon. This is how it looks inside the shoulder. It can get swollen up. It can cause a significant amount of pain for the players, and it can hinder their game altogether. And there is something called a slap lesion. I'll talk about that later. And again, a labral tear can happen. And there is something called a GAD. I'll talk about these in the coming slides. So about the shoulder anatomy, I think the previous speaker has made it very clear, very pictorial. I think most of you would be able to correlate with what I'm talking about. There are bones inside the joint, like your collarbone, which you call the clavicle, humerus, scapula, and there are tissues around the joint like the rotator cuff, which can also get injured. And most importantly, the last image, this is how an end-on view, this is how the inside of your shoulder looks like. And as Dr. Munish had explained, there are multiple ligaments both on the front, top, back, and in varied sport, in varied movements, each of these tissues can get injured. If it gets injured, it can cause a significant amount of pain and disability to the individual. So it's very important we understand the anatomy before we jump into the other talks. So risk factors, the concept of kinetic chain, I don't think I've heard such a beautiful talk about kinetic chain like the previous talk. So let's see this bowler. So yes, he comes with the run up, he plants his foot, ground reaction force is being generated, and yes, you see, it just comes back up. And the force starts conducting from the ankle, knee, thigh, the trunk, abdomen, and the shoulder. Shoulder basically acts like a funnel here. Then onto the arm, elbows, wrist, and finally the ball release. So the previous speaker was also told about 50% of the kinetic energy is actually generated in the lower limb rather than the upper limb in this motion. So be familiar with the joke, building strong, basement weak. However good your building is, basement weak arnda, you are going to sustain injury. If you're a coach, you have to sensitize your players about this. And this kinetic chain, it's basically a chain. So it's got multiple moving parts. The force move. So it involves joints, muscle, tendons, ligaments. So when your muscle is flexibility nalla illa, muscle endurance nalla illa, joint mobility nalla illana, this chain is going to be broken and it is going to result in an injury. So let's take the common or the popular overhead sport in India at least. Cricket, javelin, badminton, volleyball, tennis. So after thorough research, after studying the biomechanics of each sport, they found that with an overhead throw and overhead athlete, the biomechanics are comparable between these sports. So let's take volleyball for example. So this is, I've put up a video of the famous jump serve of Mitchell. So please kindly pay attention. Yes, the initial run up. Let's call this rider. Jump. Look at his shoulder till he makes contact. Yeah. Now, if you closely observe, you can actually break down this movement into different phases. We call this as the wind up, cocking, acceleration, deceleration, and lastly the follow. Sounds Greek and Latin, don't worry about that. I'll break down each of these phases in simple terms for you. So the first important phase, cocking phase. So ரெண்டு phase பற்றி பேசணும். இதில் வந்து early cocking சொல்லுவோம், late cocking சொல்லுவோம். What is an early cocking அப்படின்னு வந்து பார்த்தீங்கன்னா, so basically the arm goes by the side of body and starts rotating backward. So this is called as early cocking. So in medical terms we call this abduction, external rotation, horizontal abduction, forget about all that. Basically இதுதான் நடக்கும். This is early abduction. In coaching terms they call it as open shoulder configuration. Your shoulder opens up like this. So the next movement is your late cocking. என்ன ஆகும் அப்படினது பாத்தீங்கன்னா, to improve backward rotation or the external rotation, what the body does is the shoulder actually moves forward like this. So this is called as a closed shoulder configuration. Basically it goes from an open configuration to a closed configuration. So this is the movement, and while this happens, the scapula muscles na, the back muscles, the shoulder blade muscles actually stiffens and stabilizes the scapula so that this movement is facilitated, and energy build up happens in the lower part of the body as well as the trunk. So as shown in the image, this is early cocking where the shoulder opens up, and this is the late cocking. As you see, the shoulder actually comes forward and closes while increasing the backward rotation. So this is the cocking phase. And what injuries can happen during this phase? So the first and the most common one is the rotator cuff pathology. Rotator cuff is the cuff of tissue which actually attaches onto the arm bone. So this is the humerus. So I'll play a short video. See, when with repeated movement like these, as you can see between the bones, the tissue gets rubbed off and it can get angry like this. We call this inflammation. And there is a soft cuff of tissue which called the subacromial bursa, which can also get inflamed. And with repeated intensity, it can result in a tear like this. So this is the commonest injury which can happen in terms of rotator cuff. So the next common injury is the long head of biceps pathology. Basically, the biceps tendon inside the shoulder can get injured. So repeatedly the கையை தூக்கி திருப்பும் போது என்ன ஆகும்னா the tendon which is biceps, as you all know, is a thick fleshy muscle. ஆனா ஷோல்டருக்குள்ள போகும்போது வந்து பார்த்தீங்கன்னா it's got a very very small thin tiny attachment. So this tendon has to endure on to significant amount of force and rotational forces like torques. இதனால என்ன ஆகும்னு வந்து பார்த்தீங்கன்னா we'll see what happens here. So see, it can get inflamed like this. As you see in the video, the tendon itself can get thickened, and this can cause significant pain, anterior shoulder pain, especially to the athletes. And over time, it can separate from the attachment on itself. We call this auto amputation. And another type of injury which I would like to really stress upon here is, as shown in the video, see, it can get detached from the place where it attaches onto the shoulder. This is the slap injury which is widely being talked about now, and almost one of the previous delegate also asked a question about this. So this is the slap னு பேசுறது இதுதான். The biceps tendon shoulder எங்க அட்டாச் ஆகுதோ அட்டாச் ஆகிற இடத்துல கிழிஞ்சிரும். அதுதான் slap lesion சொல்லுவோம். And when an overhead athlete tries to throw a ball, this causes significant amount of pain. And the throwing motion it can cause that much of pain. So I'll take 2 more minutes. And about the acceleration phase, இது என்ன ஆகும்னு பார்த்தீங்கன்னா extra rotation, வெளி பக்கத்துலேருந்து ரொட்டேட் ஆகிறதுலேருந்து the shoulder starts rotating internally உள்ளே கொண்டு வரும். And this is a very very explosive phase. And during this phase என்ன வந்து the arm bone, the humerus moves forward with violent velocity. அதனால் ஃப்ரண்ட்டில் இருக்க டிஷ்யூலாம் கிளியலாம். So the first injury which can happen is a labral tissue, which is a cuff of tissue which sits on the anterior part of or the front of the shoulder. This can get torn up. When happening with significant intensity, the humerus, the shoulder itself can move forward and can dislocate itself, resulting in a lesion called the Bankart lesion. So this is how that movement happens. So the last injury is the tissue on the front, the rotator cuff, the subscapularis can also get injured if this happens with significant intensity. The last phase is the deceleration phase. இது என்னன்னா பாலை அத்லீட் அடிச்சதுக்கப்புறம் கை கீழே வர ஆரம்பிக்கும். இந்த மூவ்மெண்ட் நடக்கும்போது என்ன ஆகும்னா the arm basically moves out of the body with significant velocity, and significant forces are generated inside the body so that the arm doesn't move out. இது என்ன சொல்லுவாங்கன்னா it is almost equal to the half of the athlete's weight. அவ்வளோ ஃபோர்ஸ் வந்து ஜென்ரேட் ஆகும் உள்ள. ஸோ அண்ட் இது நடக்கும்போதே வந்து பார்த்தீங்கன்னா போஸ்டீரியராக இருக்கிற டிஷ்யூ எல்லாமே வந்து பார்த்தீங்கன்னா they tighten so that the arm doesn't pop out of the shoulder. And this is around 40 to 50% of the, again, forces counteracted here of the body weightலேருந்து. ஸோ இதில் இந்த பர்டிகுலர் டைப் ஆஃப் இன்ஜுரி GERD, glenohumeral internal rotation deficit னு சொல்லுவோம் மெடிக்கல் டேர்மில். ஒன்றுமே இல்லைனா I used to play tennis as a child. ஸோ இப்போ I'll put myself as an example. This is my dominant hand, right hand. இப்போ என் கையை நான் இந்த சைடு ரொட்டேட் பண்ண போனேன்னா I can rotate, இவ்வளோ என்னால் ரொட்டேட் பண்ண முடியும். அதே என்னோட லெஃப்ட் பார்த்தோன்னா என்னால் இவ்வளோ தான் போக முடியும். As a child, probably my glenohumeral joint adapted. ஆனால் என் கை இப்படி உள்ளே திருப்பும் போது ரைட் சைடில் இவ்வளோ தான் எனக்கு வர முடியும். ஆனால் with my normal, apparently normal, on the left side, I can do this much of a rotation. So this is called as GERD. So when this entire arch in the movement வந்து பெருசாக குறையில அப்படின்னும் போது it's not going to affect the athlete much. My day-to-day activity is not affected. I have a normal life. I operate, I do my routine activities. So எப்போ ப்ராப்ளம் பண்ணால் the simple way to check is ask your athlete to touch their back. The affected sideல வந்து பார்த்தீங்கன்னா this is the affected side, இவ்வளோ தான் போகும். ஆனால் நார்மல் சைடு வந்து மேலே வரையும் போகும். So this is one simple way to find out whether the athlete is having this internal rotation deficit. So my take-home message would be, understanding key biomechanics is very very important for injury prevention, and injury prevention and performance enhancement go hand in hand, and coaches and athletes and the players have to understand this and always individualize your program. Focus on strength and flexibility, proper condition, proper warm up and warm down, both are important, and proper exposure along with proper recovery time is very, very essential. This is where most of the people falter. Focus on that and teach your coaching fundamentals to the athletes. Let them learn. In the injury, eppadi nadakudunu avangalukku therija, you can prevent it better, and also focus on proper nutrition. So thank you, Ortho-One, thank you, Sham sir, and DVSR, my mentor, for this wonderful opportunity. Thank you.
Thank you, Prashant. That was a very in-depth, simplified analysis of the biomechanics of shoulder. You can wait down. We will be having the discussion pretty soon. I request Dr. Vinay Kumaraswamy to come up to the stage and start his presentation on injury prevention strategy. Dr. Vinay Kumaraswamy is a sports medicine consultant in Bangalore.
Very good morning to everyone gathered here. Big thanks to David Rajan sir, to Sham for having me here. One observation I'd like to make is I see more people near the tea stalls than people sitting here. I am okay with people being near the tea stalls, but let them focus their attention towards the dais and listen to the lectures also. And we've already gone through so many lectures. Some people are yawning, some people are looking into their phones. So let's do certain simple exercises so that the blood flows back into our brain also. Can I ask everyone to stand up, including the medical stall people? Yes. Can we do some eccentric Achilles tendon lengthening? Stand on your toes, get down. Do you feel that stretch in the back? You should feel that stretch in the back. Do you feel that stretch? Yeah, that is when you're actually
the glutes
doing
is stretching.
Yes. So, good. 5 times. Can we do some posterior capsule stretching? Posterior capsule is a very important pathology that we have. Posterior capsule stretch. Wonderful. Posterior capsule stretch. Now you may all sit down and listen to the lecture.
No massage?
No massage. That is for after the talk. Thank you. So I'll be talking about injury prevention in shoulder. Injuries are quite common during sports. You can see Shane Watson falling down and dislocating his shoulder. He was out of action for nearly 6 months after this injury. He had a surgery, then he came back. But it is avoidable. It is most injuries cannot be avoided, but it is preventable. So we are here to tell you how to prevent injuries as much as possible. However, certain injuries are not preventable also, like domestic violence. Please don't come to us with this. We'll not be able to help you. If this is your personal problem, please don't bring it to us. So, is injury completely preventable? We've heard people say time and again that injuries are not completely preventable. Injuries do happen. If a coach tells that my athlete has never got injured, if an athlete tells I am not injured, then that's a lie. I am a full marathoner. I've gone through my share of injuries. I am preparing for a triathlon now. Injuries are quite common. 18 to 61% of overhead throwing athletes have injuries. These are significant injuries, not niggles that become all right the next day. And 90% of elite swimmers have injuries. That means if you see 10 swimmers standing in front of you, 9 of them have gone through significant injuries. So injuries do happen. But how to reduce the scale of injuries? Why do injuries happen? It's because overhead athlete or overhead throwing is a very complex mechanism which involves a lot of body parts and supraphysiological load, as Muniz had pointed out, and they do happen. So how do we prevent injuries from happening? There are 4 steps to preventing injuries from happening. First is identifying the problem. This is the most important slide in this presentation. You have to identify what is the problem with your athlete. Next, you have to identify what is the injury mechanism. How is he getting injured? What are the risk factors that he has? The third is, once you identified the problem and found out how exactly it is happening, you introduce a preventive program. And then finally, 4th step is repetition of 1st step. You again assess whether the injury has recovered or not. So identifying the problem. I'll give you examples of problems later on, but who are to be involved in identifying the problem? As was elucidated earlier also, the player is the center of our universe, and the coach helps in identifying what problem the patient is or the athlete is suffering from. Physiotherapist's help can be sought when it is beyond the coach's ability to identify what exactly is wrong, and orthopedic surgeon and sports medicine specialists are also involved. So it is a team thing. As was pointed out earlier, an orthopedic surgeon also cannot diagnose properly unless he knows what sports you are playing, what is your particular activity. It's like three blind men are trying to identify and describe an elephant. So it is a team game, including preventing injuries and putting the athlete back on the field. It's a team game. So what are the problems that can be identified? There could be a labral tear. There could be an impingement, which has already been elucidated to earlier. There could be a rotator cuff tear. There could be a muscle or bone pathology. So once this diagnosis has been established, this is why he is having pain, because his labrum is not working properly, because he has a tear in the labrum, because he has altered biomechanics. Then why is he having the problem is the next step. Step 2 is to identify risk factors and injury mechanisms. So there are two kinds of risk factors. One is modifiable risk factors, other is non-modifiable risk factors. Non-modifiable risk factors, as our coach sir was asking, that I was performing so well earlier. 30 years I've been a tennis player and a tennis coach. Now I am not able to perform. Age is a non-modifiable risk factor. We all age. Sex is a non-modifiable risk factor. Female athletes are more prone to having injuries than their male counterparts. It could be the hormones, it could be the way their physique is built, but female athletes are more prone to having injuries. Then there are modifiable risk factors. Let us concentrate on that. Let us concentrate on what things we can change. There could be lack of strength in certain muscles. There could be lack of range of motion in certain group of joints. Smoking is a very important risk factors. Occasional alcohol once in a week doesn't affect your body much. One cigarette is also bad. One cigarette is also bad. Do you know Shah Rukh Khan? All of you know Shah Rukh Khan. Yeah, we had our Arthroscopy Society meeting in 2015. Shah Rukh Khan had come to that meeting. He had a rotator cuff tear. We all know he's a chain smoker, and he didn't have any injury. He didn't have an injury, and without that, he had a rotator cuff tear. One of our colleagues, Dr. Sanjay Desai, had operated on him 1 month before the conference. So he invited him, why don't you come over? So he came in with a sling. So smoking is something which is very bad. Even one cigarette is bad. So no smoking at all. Occasional alcohol once in a week, moderate amount is okay. GERD, Prashant has already spoken about. More than 18 degrees glenoid internal rotation deficit, more than 5 degrees total range of motion difference between the two shoulders is a big cause for shoulder injuries. So that has to be addressed. I taught you one posterior shoulder capsule stretching exercise. Posterior capsule tightening is also a big predisposing factor for injuries. Scapular dyskinesia, Sham has already elucidated too. You just turn your athlete and look at his back, look at him perform movement. If there is any difference between the way one scapula moves compared to the other, he has an issue there, which has to be corrected. Usually it's a muscle imbalance. Serratus anterior muscle is at fault, generally in scapular dyskinesia. So once you've identified, you've got to assess how your shoulder athlete is performing. There are various tests for that, which you can install in your physio or your coaching place. There's an upper quadrant Y balance test. I'll go through that. This is upper quadrant Y balance test, for which you need to order this particular thing, where amount of displacement that the athlete can make in 3 directions are measured, and these are serially monitored whether he is improving compared to his earlier. Seated medicine ball throw is again something which you can simply establish. Let him or her sit with the back touching the wall, and throw the ball, see how far it lands, and see whether it's improving with time. The simplest, without much equipment, is kinetic chain upper extremity test. Ask them to do a closed chain push-up and ask them to move from one side to the other side, touch the other hand in 15 seconds. and see how much they are able to perform and whether they are improving with time. So these are the simple tests. Injury mechanism, whether it's acute or chronic. Did he have that injury once, he fell down and then he had the injury, or did it accumulate over a period of time? Accumulative injury can be because of chronic overuse or fatigue. We treat a lot of athletes. Most of the injuries happen at the fag end of the training. When you are tired, you're trying to push yourself harder. That is when your injuries happen. That is when you need to be more careful. So the fag end, the last 15-20 minutes, when you're trying to push your athlete, that is when you got to be more careful. And maybe we should not push them too much, especially at the end of the session. So once we've identified why this is happening, we can introduce preventive measures. That could be strengthening exercises, that could be stretching exercises. We can change the rules so that they don't get injured that frequently. Protective equipment can be used. At the same time, again, kinetic chain, kinetic chain, kinetic chain. One more time, kinetic chain. Let's not stand too close to the trees that we'll lose sight of the forest. We are looking at the shoulder, shoulder, shoulder. He has shoulder pain, he has shoulder pain. But kinetic chain is at fault. You had a shoulder injury because you have left hip weakness. It's very hard to understand that. People have that expression. When we say that, you had left shoulder injury because you had right hip weakness. If you don't take home anything from this talk, you got to understand that kinetic chain is very important. Every part of the body is contributing to the injury, not just that particular joint. So we've kinetic chain question: how much of the power is generated by the right shoulder in an overhead smash? The answer has already been given. It is only 13%. If you hit an overhead smash, only 13% of the power is generated by the right shoulder. More than 50% is generated by the opposite hip. So if you take out the jump from the smash, the same power will not come. So again, realize the importance of kinetic chain, realize the importance of strengthening other parts of the body also. For a shoulder, for a footballer, they've got to strengthen their upper body also. And for an upper body athlete, they've got to strengthen their lower body also. Step 4 is, again, see if it's recovered or not. Okay, we come back to the same Rohit Sharma fixing video, quiz time. This was a World Cup match, World Cup in England. He had a dislocation and he fixed it himself, reduced it on field himself. So let's go through the 4 steps again. Step 1, what is his problem? Any guesses? There was a class on anatomy and all. He has a labral tear. He has a labral tear, that is where the shoulder is dislocating. Okay, step 2 is, why does he have a labral tear? It could be a huge injury at one point in time. Maybe his technique was not right while falling, while fielding. That's why he had an injury. I'll just take last 1 minute. And his strength is not adequate. So how do we correct that? Step 3, there is no conservative management there. He has to undergo a surgery to fix it. Okay, but he's not getting the surgery done because he is not a bowler. If you're a bowler, then your other shoulder also becomes very important. He's a batsman, he's managing with that. So 90% of shoulder injuries don't need surgery. More than 90% don't need shoulder injuries, don't need surgery. However, there are some conditions that do need surgery. There's nothing else that will work. Doctor, surgery mattu venda vera edadru pannunga. Not possible in some conditions. You've got to understand that. You've got to trust your doctor whom you're going to. So, and you've got to get the surgery done for certain pathologies. So, final message, kinetic chain is important. Strengthening and stretching is important. Appropriate diagnosis is important. It's always a teamwork. The coach, the physio, the doctor and the athlete are a team in recovery also, not just in sports. Injury prevention, warm-up is extremely important, as was pointed out by sir, which athletes don't do. Warm-up is important. You cannot stretch a cold muscle. Okay, you can't just get up in the morning and start stretching. Won't work. You have to warm up and then you have to stretch. Okay, remember that one sentence, you cannot stretch a cold muscle. You'll have to warm up and only then stretch will work. Cool down is very important. If you do all this, your shoulder will say, wonderful, I'm great. And no matter what happens, no matter what life throws at you, your sport throws at you or your wife throws at you, your shoulder will not get injured. Prevention is always better than cure. Mind it. Thank you.
Thank you, Dr. Vinay. I should say that Vadivelu's memes are immortal.
Yes, yes.
Last
yes.
for a longer duration, so we can learn from him as well. Thanks a lot for this fantastic presentation.
Thank you.
Next is the most important talk, which we should always look out for. Coaches, trainers, please watch out for this beautiful talk from Dr. Santosh Sahanand, being a Pied Piper. Guide your athlete the right way.
Thank you, Shyam. So, being Pied Piper, I was just asking my colleague over there, what is Pied Piper? அப்படின்னா அப்படின்னு கேட்டால் அப்படி அப்போவே தெரிஞ்சிருச்சு ஓச்சரா யாருக்குமே இது என்னென்ன புரிஞ்சிருக்காதுன்னு. யாருக்காவது தெரியுமா Pied Piperனா என்னென்னு? யாரு? எனிபடி? Pied Piper என்ன தெரியலையா? ஓகே. இப்போது ஞாபகம் இருக்கா சின்ன வயசில் படித்த? ஸோ என்னது Pied Piperனா என்னது? இந்த கதையை ஃபஸ்ட்டு சொல்லணும். அப்போனா
anyone should get up and answer. If you know, it's better that you answer.
ஸோ ஓகே, இது ஓகே. Pied Piperனா ஒரு ஊரில் வந்து நிறைய எலி இருந்துச்சு. எலி இருக்கும்போது சாரி, ஐ எம் டாக்கிங் இன் த லோக்கல் லாங்குவேஜ், மார்டின். ஸோ எலி இருந்துச்சு. எலியை துரத்துறதுக்கு நிறையா மெத்தட்ஸ் ஃபாலோ பண்ணாங்க, எதுவுமே வேலை செய்யலை. ஸோ இந்த Pied Piperன்னு ஒருத்தனை கூப்பிட்டோம். ஹி ஹேட் ஃப்ளூட் ஒரு ட்ரம்பெட், ஒரு மியூசிக் வாசிச்சு அப்படி எல்லா எலியும் பின்னாடியே போயிடுச்சு. அவனுக்கு நிறையா காசு கொடுக்குறேன்னு ஃபஸ்ட்டு சொல்லியிருந்தாங்க, காசு கொடுக்காம விட்டுட்டாங்க. அவனுக்கு கோவம் வந்துடும். ஸோ அவன் வந்து அங்கே ஊரில் இருக்கிற குழந்தைங்களுக்கு எல்லாத்துக்கும் ஒரு மியூசிக்கை போட்டு குழந்தைங்க எல்லாத்தையும் கூட்டிகிட்டு போயிடுவான். ஸோ பேசிக்லி ஒருத்தர் சொல்கிறத மிச்சவங்களை எப்படி கேட்க வைக்கிறது, வாட் ஆர் த டிப்ஸ் பிஹைண்ட் மேக்கிங் சம்படி லிசன் டு யூ. ஸோ this talk is all about mind. So how to, for a trainer or a coach, how to make people listen to you. So it's more of a psychology talk or a psychiatrist talk, but இது எல்லாத்துக்கும் தெரியணும். any doctor, any trainer, any coach, any teacher, any people who are in the team must know this psychology. So that's the essence of this talk. So இதை வச்சு how can you guide your athlete? Why did we think of bringing this talk now? Adherence to stretching program, that was a very, very important factor. In a team, when you wanted to give a program of stretches, which is including warm-ups and cool down, adherence to that program is very poor among athletes. So when you give a program as a trainer or a coach, your athletes do not stick to that program. So how can you make them stick to your program is what we are going to see. These concepts were adopted from various other fields. I'll try to brief, which is the scientific basis for this. For first thing, I would, for a Pied Piper, your appearance. You must stand out as a trainer or a leader. You must stand out as an individual. In a crowd, you must be visible. And you must be loud. Being loud is very important. For that, I would like to show this. This is a famous in a Tamil movie. So.
Good morning, coach. Good morning, coach. Good morning, coach.
Kekala.
Good morning, coach.
Kekala.
Good morning, coach.
Sattama.
Good morning, coach. Good morning, coach. Good morning, coach. Morning, coach. Good morning.
So being loud is very important, but at the same time, sometimes silence also has a lot of meaning. So you must know when to be loud and when to be silent. You cannot be shouting at your athletes every time. You must need to be silent. That also conveys a lot of meaning. And you must command respect among them. So
Good morning, coach.
Kekala. Sattama.
So everybody cannot get that same respect as the individual leader. Which there are tips to get that respect and make people follow you. It doesn't come for everybody, but there are certain psychological aspects attached to this. There might be other values, star values, or something which is unexplainable, which is attached to you. We'll see what it could be. Some are explainable, others are not. These are 4 concepts of parenting. பேரண்டிங்னா ஒரு குழந்தைய கொண்டு வளர்க்குறதுல எந்த மாதிரி வளர்க்கலான்றதுக்கான 4 different methods of parenting or bringing up your child. The one in the yellow is authoritarian. Authoritarian na Hitler mari. So whatever you do, you have to do. சொல்லியாச்சுன்னா செஞ்சு தான் ஆகணும், நான் சொன்னேன் நீ செய்யணும் அப்படின்னு சொல்கிறது தான். அது பண்ணாட்டி பனிஷ்மெண்ட் கிடைக்கும், அதனால் பண்ணியே ஆகணும், கேள்வியே கேட்கக்கூடாது. தட் இஸ் அத்தாரிட்டேரியன். ஒரு எக்ஸாம்பிள், இது என்ன படம் யாருக்காவது சொல்ல முடியுமா? தங்கல். யா, இதில் சல்மான் கான் பண்ணுறது வந்து ஆல்மோஸ்ட் லைக், ஆமீர் கான் பண்ணுறது வந்து ஆல்மோஸ்ட் லைக் அத்தாரிட்டேரியன். அவங்க 2 டாட்டர்ஸ்க்கும் கேள்வியே கேட்க விட மாட்டேன், அப்படி சொன்னதை செய்யணும், யூ மஸ்ட் டூ, அதர்வைஸ் யூ வில் பி பனிஷ்ட். ஸோ தட்ஸ் ஒன் கான்செப்ட் ஆஃப் training and bringing up and method of training people to listen to you. So other little opposite of authoritarian is totally uninvolved. என்ன நடக்குதுன்னு எனக்கு தெரியாது. இந்த பிக்சர் பார்த்தீங்கன்னா தெரியும், அப்பா வந்து குழந்தை அம்மா தான் பார்த்துப்பாங்க, அப்பா ஏதோ விளையாட கொடுத்துட்டு see the TV. This happens in most of our houses. ஸோ இது வந்து குழந்தைய பார்த்துப்பாங்க பட் நாட் இன்வால்வ்ட் அட் ஆல். ஸோ அந்த மாதிரி இருக்கிறது டோட்டலி அன்இன்வால்வ்டு. ஸோ இந்த மாதிரி கான்செப்ட், இது எந்த மூவின்னு யாருக்கா தெரியுமா? 1983, which is the Indian World Cup winning squad. PM மான்சிங் அப்படின்னு இருக்கிறவர் தான் அந்த ஃபோட்டோவில், அவரோட கேரக்டர் தான் யஷ் பண்ணியிருந்தது. He was not a coach basically, he was just a manager. He does not get involved with coaching and other aspects, but he's just there to support the team, uninvolved. He's there to support, but he doesn't get involved in the coaching aspects. This is the opposite extreme. Authoritarian opposite is this one. So the compliance of the athlete varies from each one. Certain athletes will suit into certain categories. சில பேருக்கு அத்தாரிட்டேரியனாக இருந்தால் தான் செய்வாங்க, சில பேர் அன்இன்வால்வ்டாக இருந்தால் தான் நல்லா பெர்ஃபார்ம். யூ ஹேவ் டு பி ஏபிள் டு சூஸ் இட். பட் இன் ஜென்ரல் the best way would be authoritative otherwise. The one on the blue, where you go along with the kid, discuss with the kid, give the positives and keep talking, let's do it. It's like you, not like you do it, let's do it, let us do it. நம்ம 2 பேர் சேர்ந்து பண்ணலாம் வா அப்படின்னு சொல்லி பண்ணுறது authoritative. Authoritarian is different, even though it sounds similar. Authoritarian is more of Hitler-like. The authoritative is like, let's do it together. So example would be like, இது என்ன மூவி, இது எந்த படம்? ஷாருக் கான். சக்தே எல்லாரும் பார்த்துருப்பீங்கன்னு நினைக்கிறேன். Is there anybody who's not seen சக்தே? So இதில் வந்து he would be part of the team, he will encourage them and he would make them do it along with him. Like running, he goes for the morning run along with the team. He does everything with the team. So he belongs to the team and it's more of authoritative. It takes the kids along, keeps discussing with them. It is considered one of the best way of bringing up a kid. At the same time, best way of bringing up a team. Can you quote an example of bringing up a team like this? So I would quote this person. MS Dhoni, as you can see in most of the social medias, he is being considered the best captain or the best coach currently in the cricketing world. You can see Sunil Gavaskar getting the signature. All of that is because of his characters and the way he brings up his team. All his team members who were ex-team members praise him for the way he brings up the team. He is not authoritarian at all. He is authoritative. He talks, every match you see him, he just stares at the players but doesn't scold them, but he commands respect from them and they come and follow him. He discusses various things, all inputs from various people are taken into consideration and then decisions are made. So he is a very good example of an authoritative, where he takes them along with him and discusses things. Other one which is less effective than this is the permissive. Permissive, you don't force anything on the kids or the players, but you keep a watch and keep giving inputs. You don't get involved with them, but you keep a watch on them. This is slightly less effective, but for people who do not want to be interfered a lot, it might be suitable. So these are the 4 concepts, but the best would be authoritative. But in situations, depending on that individual or the team, you might need to adapt to move to authoritative or be uninvolved also. So these are the 4 concepts which you must be familiar with. So any athlete must be motivated. So motivation, you must know of the two concepts, where it could be intrinsic or extrinsic. These two images would actually convey the meaning, where extrinsic is something where others keep telling you, இதை பண்ணு அதை பண்ணு இது பண்ணணும் அதை பண்ணணும்னு. Intrinsic is your motivation, where you wanted to do it yourself. It's for your wishes or your pleasure you doing it. உனக்காக எனக்கு இது பிடிச்சிருக்கு அதனால நான் பண்ணுறேன். For the second, the blue image shows that you love playing football, you like playing football, so you play, you enjoy the game. Again, Dhoni comes as an example here, where he tells his player, you just go in and enjoy the game, play to your potential. He doesn't say, we want to win the cup today. He never says that in the final or any time. He just says, you enjoy the game, put in your full potential. So your anxiety level will be less, your motivation will be more, you will be motivated for your own pleasure rather than but extrinsic motivation is also important, where you play for the cup, you want to win and you play for the team. But intrinsic is more important than extrinsic. You personally need to want that. So you must be aware of these two concepts. Both kind of motivation is required, but intrinsic motivation is more important. So as a trainer or a coach, you must be aware how much an athlete is intrinsically motivated. So you need to push those intrinsic motivations by giving external force, by giving credits where they have this intrinsic motivation. But extrinsic motivation rather than credits, more of punishments will be slightly more suitable. So all that varies, and coaches must be aware of the individual athletes and train them as per their strengths and weaknesses. So apart from motivation, when it comes to a trainer and an athlete, getting a good relationship between those two persons is very important. It starts right from the day they join the academy or the course, where if parents are involved right from the beginning, if parents are made aware of their routine. For example, when you come in and as a person, you come in the morning, we do stretches, we spend time on stretches, then we have a program of so many hours, then we do the post stretches, then these are the nutrition. When parents are explained about their full routine, compliance is better. When the kids goes back home, when they tend to complain, today was tiring, they made me stretch a lot, I was made to work more than the others. If in time zero, before they join, if parents are made aware that certain people are prone for certain type of stiffness, so certain people will be worked on more than others, parents would support you and they won't complain. They would rather reinforce the kid or the athlete that this is done for your good, so it's better for you. So time zero, before they recruit, family is involved, and more time is spent on an individual, talking on an individual basis. As a team talk is different, individual talk is different. So how many of you have seen this movie? Mithali Raj's biography. Can I see a show of hands? How many of you have seen this movie? This is a fantastic movie, but I can't see much. It's available in OTT. You should watch this movie, where you would see the coach and a player relationship in this, where the coach and his involvement with the family, how she was brought up and how she was trained. It's a good movie, and the entire relationship between a coach and a player is well brought out in this movie. So as an individual, you must be briefing the entire routine to the player, and their weaknesses and their goals also must be brought in front. And again, when they come for awareness programs, you can show the videos of the ex-players who had gone through this rigorous training. So they would feel that they are not the only people being targeted. They know that everyone has gone through the same thing. So it's not something to complain about, and they have to go through this routine. All these small things increases the relationship between the player and the coach. So individual goal setting. So each individual will be different. Each individual's talents will be different, physical abilities will be different. So goal setting must be done individually, and you must work towards that goal. This is a small way of doing it as smart. It must be specific. You must be able to measure the goal. It should not be just an arbitrary goal. It should be attainable for that particular individual. Unrealistic goals should not be given to an individual. So that's why it must be individualized. It must be relevant for that particular sport, and it must always be time-based. You must have a timeline, and you must work towards that timeline. So it must be personal, and the team must be aware of each individual's goal. So the team as such can help a particular individual within their team to attain the goal. Goals might be different for each individual, but the team members also, when they contribute to this, the adherence to this program will be better. So, okay, coming to almost the second last.
சாப்பாடுனா முதல்ல ஓடி போக தெரியுதுல, கிரவுண்ட்ல ஓடுனா மட்டும் உனக்கு அவ்வளவு கஷ்டம் இல்ல? ஓட சொன்னா உருள்ற நேடிது
கோச். அப்பலாம் பேசாதீங்க கோச்.
கொட்டிக்கிறல, எதுவும் பண்ண வேணா
கோச். அப்படி பேசாதீங்க கோச். நான் உங்களை அப்பா மாதிரி பாக்குறேன்.
குண்டம்மா
கோச் வானா.
அப்படி தாண்டி சொல்லுவேன், 1000 தடவை சொல்லுவேன். குண்டம்மா என்னடி பண்ணுவ? இந்த கோவத்தெல்லாம் கிரவுண்ட்ல போய் காட்டு. சும்மா
கோச் யாரை பார்த்து குண்டம்மா?
உன்னை பார்த்தாண்டி சொல்றேன். குண்டம்மா.
என்னப்பா இப்படி பேசுற?
கொளுத்தி போட்டுருக்க. அடுத்த 40 நிமிஷம் புள்ளிங்க தீயா இருப்பா.
So, you know which movie is this? I'm not going to ask which movie. But how many of you have come through this situation? Maybe as an athlete, maybe as a coach. Please show of hands. How many of you have come through such situation where your coaches scold you badly for your? I can see 1, 2. Please, more. I've come through this situation. More. So, how many of you think this is wrong? Okay, I can see. Okay, how many of you think it's right? Okay, I can still see. Good. Okay, so I would say both are right. It's partially right and partially wrong. Maybe personal comments where they hurt the feeling of that particular individual, maybe called as body shaming, might be wrong. But being strict or punishing an athlete is part of a training program. So it cannot be told as something which is wrong. So there must be an environment which is good enough or primed for that individual. It could be rewards or it could be punishment. Certain individuals respond better with rewards. Certain individuals do not respond with rewards. They need to be pushed. So identifying those individuals is very, very important for your as a trainer or as a leader, and they must be pushed. This is not an arbitrary thing. There are clear-cut evidences to prove this. There are studies of juggling, an athlete doing a juggling, and they were put into these kind of programs where you get rewarded or you get punished when they make mistakes or when they do it well. Their cortisol levels were measured by, saliva cortisol levels on periodic intervals, and it showed totally punishing somebody does not give an advantage. But mix of both is required. The study actually had 50-50, 90-10 of rewards. Both 50-50 and 90-10 showed beneficial cortisol standard levels than spiking. When the cortisol levels are not spiking, performance and training and health on long term is better. So mix of both is important, and it should be, adherence will be better if it's fun filled. All the time punishing might not be suitable. It should be enjoyable kind of program which the particular trainer must design. So you call this as cognitive bias. Why does an individual hesitate to do certain things? As in the video, as an example, she does not do certain things. If you can take that as an example, she is overweight, but she's talented, but she's not able to do certain things. If you take that example, if you can see, there might be a attention deficit that in the field that she needs to do that. There'll be a lack of individual motivation that is intrinsic, or there'll be social pressure that somebody might see her running with such an obese body in the stadium. That might be a social pressure. or it might be thought block, or there might be a intrinsic depression at that point of time. There are so many factors which will stop an individual from performing or doing that particular activity. So exposing that particular individual to this repeatedly with positive imagery, repeated training will help them come over it. It can be with reward or with punishment. Mix of both is what is recommended. At the last is the positive imagery. Positive imagery is positive thinking and thinking of those difficult situations before you go on field. So making that person get exposed with those images is something we have another talk on this by Sarthak. So all of you must be aware of something called positive imagery. There is a lot of latest information and literature on this field. This has a major effect on the performance. So thank you. Any more discussions? And we can go ahead and discuss.
Thank you.
Further.
Thank you, Dr. Santosh. Thanks a lot for this fantastic talk. Before we go to Dr. Manish Arora's talk, we'll have a discussion on these segments of topics which was discussed. Do we have any questions from the audience? Because it's very difficult. When we prepared this talk for the day 2 program, I never had an idea of enhancing the mental ability or how to become a good trainer. And Santosh always thinks out of the box. And he is the right person to talk about this. Such a pleasure to have listened to your talk. Any questions from your side? Any doubts or anything? Any suggestions? Which means yes, please come forward.
Hello, good morning, sir.
Good morning.
Sir, could you elaborate on that GIR? You told me something, right?
Yes, correct.
Yeah.
See, what will happen is whenever an athlete is throwing, when he's throwing, his shoulder is subjected to a lot of stress and strain. It just stretches out, stretches back in. Okay. Now, what happens is, in order to compensate for the increase in external rotation, that is, to rotate externally more to get the acceleration and the deceleration going, there is compensatory loss in internal rotation, which means on the normal shoulder, if his shoulder is going up to the back, in the affected shoulder, it just rotates this much, that's all. This loss in rotation internally is compensated by gain in external rotation. All right. So, if the gain is not there, which means if there is loss in internal rotation and the expected gain is not there, then the athlete is prone for more injury. All right. So, that's what is called as glenohumeral internal rotation deficit. So, we have to watch out for that.
Sir, actually with time, the range of motion gets improved, right, as an adaptation.
Correct, absolutely.
Like, why is it happening? Like, if you are using the hands for a longer duration for a particular time, it must become more flexible, right, as a result of adaptation. Okay. Why does the non-dominant hand is better than the dominant hand then?
Absolutely right question. That we must know, all the overhead athletes should know. This adaptation is a selective adaptation, not a global adaptation. It adapts selectively to improve the external rotation, but not the internal rotation, and that's what we are trying to find out why it's happening. There are many factors, because the capsule, the posterior capsule of the shoulder joint contracts. When it's subjected to these supraphysiological forces, it contracts, and that's the one which prevents more internal rotation. And that's a pathological condition. That is definitely pathological, and we have to get all the maneuvers and all the practices to prevent this from happening. And that's what we are going to explain to you on the patient's fitness to get back to injury management, which Paul will be talking about. So you can learn from that.
Okay, sir. So one more doubt.
Yeah.
Like you told me that subcapsularis, right?
Subscapularis muscle.
Where does it, like, it is at the front or at the back?
It's actually over here, near the axilla, this area from the shoulder blade. Okay. It comes from the shoulder blade, comes and attaches in front of the shoulder over here, which is very important for rotating the shoulder inward, inside.
So
okay,
it's a muscle, like it's a tendon. Is it a tendon or a muscle?
It's a muscle from the shoulder blade,
okay,
which comes and inserts onto the humerus, onto the shoulder area as a tendon.
So in the front region.
Exactly.
Is it coming like
so
this?
it helps in internal rotation.
Okay, all right.
Yeah.
Okay, thank you, sir.
Thank you.
Tarun, I'll just elaborate on the GERD. Tarun, are you a normal person? Yeah. Okay, fine. Let's do a check on you. Cameras are focusing, lovely. Are you a right-hander or a left-hander?
Right-hander.
Right-hander, okay, fine. So we'll check your right hand. Make a fist, thumbs up. Yes, how high can you go? That high, okay, I'll hold my finger there. Yes, out. Left hand, how high can you go? How high can you go? Yeah, slightly higher. Yeah. Do you think it's normal? Both the sides are equal? Can you feel my fingers on your back? You have more internal rotation on the left side, this one. You have less internal rotation on the right one. So you're a normal person, no? You have GERD, you have glenoid internal rotation deficit. Everyone has that. Okay, all of us gain external rotation. There is something called as total range of motion. So external rotation plus internal rotation will be constant. If you are gaining more external rotation on the dominant side to perform activities, you are losing internal rotation. Only when you lose something, you will gain that, because the total range will be the same. So all of us have more internal rotation on the non-dominant side. But if the difference is more than 10 degrees, 15 degrees, 18 degrees, then those people are more prone to injury. So it is normally different. It's not bad, definitely less than 10 degrees. So it's normal, everyone has that.
Thank you. Thanks, Dr. Vinay. Any more questions? Okay. Now, this is going to be a demonstration by Dr. Manish Arora. So, I would request Mr. Ramakrishnan and Raj Kannan to come up to the dais for moderating session. And Dr. Manish Arora will be starting his talk on myokinetic and visceral osteopathy for shoulder dysfunction.
Good morning. First of all, let me thank Dr. David, Dr. Shyamsundar, Dr. Santosh, and my good friend, Dr. Ganeshan, to have me here. It may be a little moon and Mars difference. I may sound a little alien because up north we are into a very different culture, but I love the culture in south. People are more ready to learn and grab. And I was happy to learn even a lot of orthopedicians talking about the kinetic chains and the dysfunctions. I'd never thought that will happen in North, but it is good to have it here. And, well, my talk would be, I think I've been allotted about 45 minutes, so about 25, 30 minutes. I'm going to use a little bit of multimedia animation to what I want to express myself. And then last 15 minutes, as I said, it will be Mars to Moons. It will be a very different kind of thing, which will do a live demonstration. We have all been talking about kinetic chains since morning, and I'll show you an example where I'm going to treat the trapezius muscle in some of you from the feet, and instantly change I'm trying to bring that. It may look a very different thing, it may look like a magic show, but it's not a magic show, it's something very realistic which we need to understand. So, well, my slides are always laid that way because in North we try to do a little bit of introduction about ourselves before we present. I'm working as a full-time dean in one of the oldest physiotherapy institutes. Now it's a university at Sardar Vahan Singh University, Dehradun. Well, I'm running my own clinic for the last 25 years, I guess. Yes, approximately 25. Well, 1st January we'll be completing 25 years. We see about 50 patients every day evening. Sometimes it's 60, sometimes 40, in only 3 hours. And I have other clinics in Gurgaon as well as Ananda in the Himalayas, which is one of the top-end health destination in the country. And this is intentionally I put with my staff, the famous figure, you must be knowing better than I know him, Allu Arjun. And this is another Bollywood star. He's a singer, Zubin Nautiyal. He's at my clinic. Well, I did my graduation from National Institute Orissa in physiotherapy. I did my master's in sports sciences, and then suddenly took a very positive turn in my life by adopting, or rather integrating, osteopathy and chiropractics into physiotherapy. Though they are separate professions if you go world over, but we brought this system in India, and our focus has been to integrate physiotherapy, osteopathy, and chiropractics, because the human body only understands two things: dysfunction and function. So it doesn't has the barrier of finding whether one is chiropractor, osteopath, or physio. You have to mix everything and make the person better. I've taught over more than 10,000 students regularly and in various workshops. We've done more than 200 workshops in manual therapy, presented more than 150 papers which have been published in various journals. And another little disclaimer, I'll be putting all the supporting evidences into orange boxes. I have not put the references at the end to be there itself. On the orange boxes, you'll find the references of the scientific evidences we have, what I'm going to talk about. Well, the problem we have, first of all, is that the divide of healthcare profession into different divisions has actually narrowed our vision. We have been thinking in the own way we look at it, but such a wonderful conference where all of us are integrated on one platform probably would change our viewpoint. So we have here orthopedic surgeons, we have physios, we have coaches. So we have all on a different way to look things, but I think we need to look at all together if we want to make an optimal input into patients' outcome. And to make the matters worse, till I did osteopathy, I thought I knew a lot of things about human body, but in reality it is not so. We all know is a tip of iceberg. There's so many hidden things, so many things which we have not known because nobody has put light on that. So when I started doing osteopathy, there were two challenges from me. One, to adopt the conventional approach, which had its own limitations. What was taught, what was being executed, let me do that. And then go to an unknown region. They call it Aryapata, I think, in Tamil. I'm not very good in Tamil, but I explored to go into a region which nobody knew. And that actually helped me a lot. So what I did, it was not easy to have everything new designed by my own. So I made use of some existing concepts and amalgamated them together. So this I call as myokinetics, my own kinetics, where we use techniques from osteopathy, chiropractics, physiotherapy, applied kinesiology, and acupuncture, and we all put them together into one little domain called myokinetics. And this was presented at WCPT, World Congress of Physiotherapy, Singapore 2015, and I've got patented and trademarked. So we use some very own developed facial tests. And today I'll show you, without even touching the trapezius, I'll find out whether it's trapezius or something else which is troubling in that patient, and then I'll treat it in a very different way. So this is which, out of my clinical practice, something I learned, and I translated into meaningful research, and now it's a scientific evidence that you can do that way. Why I did? Because there was always a mismatch between the intentions of doing good and the outcomes we used to get. We always thought this thing would work for the patient. It not always worked. You must have seen the example of remdesivir in India in COVID. It was sold like hotcakes, not that hotcakes, even precious than that. But later on it was claimed it never worked. So there are many things in our profession also which are believed to work but which actually don't work. The first challenge was we were living on the world of symptoms as physiotherapists. We all know when if somebody has a shoulder impingement, he'll get an anterior shoulder pain. But if you see only just the myofascial elements which should prevent the anterior shoulder pain, it could be so varied apart. So just having a look at the symptoms only ensures that we are trying to hunt something out. It doesn't mean that we are getting any concrete information of the pathology or the dysfunction patient has. So Symptoms are good lead-ups. They are not good conclusive evidences. So that was the problem in physiotherapy. Previously, we used to work on a lot of ultrasounds intense. It never mattered. If you're applying a transcutaneous nerve stimulation, if it's a shoulder impingement, if it's a frozen shoulder, if it's subacromial bursitis, you need to apply the TENS across that area. It doesn't change. But when you're doing manual therapy, it makes a big difference. Then, many times, we only see the end result of the problem. For example, pectoralis minor and shoulder impingement. So, as I said, in the red boxes, you can find the evidences. It's not that I'm talking something totally out of the box. So, there are very evidences that shoulder impingement is somehow being made responsible from a tight pectoralis minor, because it can draw the coracoid process down, and once the coracoid process is down, it can impinge upon the rotator cuff as well as subacromial bursa, and it can maintain that inflammation, it can maintain the problem to be there. So we need to work on those myofascial structures to actually add to the rehab process of restoring normalcy. And it wasn't easy. When I started working on pectoralis minor, it lies under a very thick cover of pectoralis major. So I had to really find out the way I could dig into it and release that muscle. Because if I'm just on the top of my anterior thorax, it is pectoralis major. So I could reach there and do that, and it started working better. I think this slide now is of some little use now, because we had, I think, Dr. Manish in the morning, or the other doctor, who very well said, we have been overemphasizing on the evidences that we get through MRIs. They are very important investigations, MRIs, I don't deny that, but they are not always 100% correct. Along with your clinical findings, if you relate that, you are going to get better results. So this is in the knee, I had the data. Even all tests which we do in the knee, along with MRI, it gives you about sensitivity of 80% and specificity of 95%. So the challenge was to have something which could augment what I'm thinking about into an outcome which I can understand. This is another example. These examples are from the spine, though it's a shoulder program, but I have an example here. These are MRIs of people who are healthy in terms of having no back pain. But if you see that, about 30% of the people in 20s have a herniated disc according to an MRI, and 80% of them have some disc issues at later ages. So these people are those who never have any pain of back pain or any episode similar to that. So MRI is reflecting that. So if I'm also having a silent disc, which is not troubling my nerves, which is not irritating my dura to produce a radicular pain, and suddenly I twist and turn too many times, I may irritate my quadratus lumborum, and which was emphasized by my predecessors here in the morning, that if you have more than what you can do, it will create some triggers in the muscle. And as a result, I'll get pain in the gluteal area, I'll get some back pain, which increases on cuffing, twisting, and I may start believing it's my disc. But the problem may come from quadratus lumborum. Or I may get a sciatic-like presentation, because the trigger in my gluteus minimus gives me the similar kind of a referred pain. It's not a radicular pain, it's a referred pain. Referred pains are always dull. Radicular pains are more sharper pains. But for patient, he doesn't understand this. So I may get into the gambit of wrong lead-ups. I'll not say wrong diagnosis, because MRI is reflecting that. So I may be really focused on trying to do something with the disc, which is silently being there for years. So for this, we developed into myokinetics our own slide tests, which I'll demonstrate here today. And we could find out whether it was any muscular element involved into it. And it takes just few seconds for us to find out. And then add to the investigations, MRIs or X-rays, whatever we have got into our kitty by the patient. And then this is, as I said, everybody talks this morning, our body doesn't work way. It is all kinetically connected. Though it's a shoulder conference, we need to treat shoulder, but thinking about the entire body would be better because it's all connected. You can just release the suboccipital muscles and you can see the hamstring muscle becoming change. This is what we have in kinetic connections. And I'll give you a little example here. How I can create an injury or my injury in the shoulder can become repetitive microtrauma if I have some problem. Like, for example, if I have to reach back and keep this slide pointer back, I'll require external rotation of my trunk. I'll come, I don't have a mic there, but I'll show you, and then I'll come back and narrate to you. Thank you. Right. So, we were always believing that our external rotation is being carried about by obliques, of course, QL, our longismus and iliocostal is helping into that. All those muscles were helping, but we never thought that a tibialis anterior or peroneus could play a role into that. Now, if you see, when I'm turning and trying to reach the slide changer, I'm twisting my body and reaching it very nicely out here. But if I stop my inside foot, that is the right foot, to go into supination, the left foot to go into pronation, my right leg to go into external rotation at tibia and femur, the left one to go into internal rotation, I'm here. I'm not going to reach it. So I'm going to use a lot of over supraphysiological, what they said, I really like the term in the morning, over supraphysiological movement to try to reach there and get it. So I may get a tear here. I may disturb already tight fibers here. So this is where we need to really look into the kinetic chain effect, which comes from the entire fascia being one unit. You could see here, right from your limbs to your visceral tissues, which have a lot of connective tissues, they also play a role. When I bend forward, my lever rolls over my right kidney. It's another articulation which we never look at. We think they're separate structures. But if there's a restriction of my lever rolling over my right kidney, I'll not get my full range of motion. I'll try to compensate from some other area which may be overstretched and may be broken down. So that way, I have to look at more holistically. And another effect on the shoulder. My lever is upheld by coronary ligament that attaches it to the diaphragm. So if there is some laxity in the lever, and it is very prone to such kind of laxity or ptosis, why? Normal lever weighs about 1.5 to 2 kgs. But when we are having a lot of food, especially oily food, what will happen? There will be more blood diverted to my lever. So it will become a more heavier structure. And a couple of translation going it downwards can keep on, time over time, make the lever descend a little. So once it descends, it pulls on the diaphragm. This is the coronary ligament attached on the diaphragm. And this, in turn, is going to create some continuous traction on the rib cage. And when the rib cage is drawn down, again, the pectoralis minor which is attached from the third, fourth, and fifth rib to the coracoid process will be drawn down. It will change the shoulder kinesis. It will result in the scapula getting altered into position, and as a result of which, what will happen? If I keep my arm protracted downward, see, my range reduces. So I'll have a loss of range of motion of shoulder because there's a downward ptosis of my lever. So unless I work on that, I'll try to get into overcompensation by making some tissues work too much here. The job which was done by 4 people, one was not working, I'm trying to put on other 3. So they will be at such put into more work, and they will, more work, if you are not trained, will lead to more problems. So this was the challenges I had. Many things were based on our beliefs rather than scientific evidences. So we tried to dig in. One important thing which I felt was very important when I was working as a physical therapist. This is taken from Robin McKenzie's book, which was published in 2003, one of the leaders in curing back pain through his McKenzie methods. And he said, even if you don't treat a patient, in 2 months, 84 patients will become symptomatically temporarily better. And patient comes to you only for symptoms, not for diseases. But then I realized this little thing which I've adopted from Dixon, which says, though the patient may feel that technically he's become better, but once the stress goes down, his pain becomes less, the pain becomes less. But if you don't restore the myofascial elasticity in the structures, these things tend to grow up. They come back in a worse way. Because earlier, what we are born with ease, it gets into a little dis-ease where sometimes patient comes and goes back. Then it turns into a disease where permanently it wants to come to you and get healed. And this is how most of the things progress. So the best thing is to stop it there when it is into dis-ease and reverse it back, because that time it is much easier than when it's gone into disease. And we all know we'll have these kind of dis-eases developing because we don't use our body symmetrically. Even many of you are trainers, coaches, physios, but I'm sure now some of them are correcting your postures, but it's only a very transient one. You sit there for 10, 15 minutes and then you go back into the same posture which you were. So these kind of things will happen, and our lifestyles are such this will happen. So we need to reverse them back. Because if you don't release this soft tissue things, only 2 things happen. 1, if your core stabilizers are good, this joint stabilization is good, you'll get a different picture. But if it is not good, you'll have one of the bone getting misaligned. Like the coracoid process was pulled down. And this is only a couple of millimeters of misalignment is sufficient enough to give you some kind of dysfunction. For this, you need joint cracking. Sometimes you need joint mobilizations. But if your core strength is good, don't worry. The bone won't shift. If the myofascial element has become tight, it won't shift because the core is good. But then the results are even more long-termly bad because it will lead to spurring up, as it happens in this example. The calcaneal spur being formed because of the tight plantar fascia. So it's a double-sided sword. And this is what grows up into most of the degenerative changes. I always say degeneration is not a senile problem. I have an 85-year-old person who's still running 10 miles a day without any pain, and I have a 45-year-old lady who can't even walk. So if osteoarthritis is purely a senile problem, why does that variability occur? It is more related with the alignment. It's more related with the balance. And alignment is, when I'm talking about it, the bones are not under the control of themselves. They're only under muscular control. So if there's a muscle imbalance, all the discal problems, all the spondylitic changes, all the shoulder imbalances in dyskinesis will result. I pick up one wonderful line from Dr. Shyam Sundar's thing. flexibility. Because when we are born, we can put our feet in our mouth. At my age, I cannot touch my feet. And 20 years from down the line, I'm not able to touch my knee also. So the moment we start lacking in flexibility, as I said, one thing of these two will occur. And this is what we get to trouble. And then there are more evidences. This is taken from two wonderful physicians, Treville and Simons. They believed in all the cases of frozen shoulder, about 60% input comes from subscapularies. We saw some wonderful anatomical cadaveric presentations in the morning. So the subscapularies contributes a lot into that. And there's some very local South Indian people who have done some wonderful research and presented a journal of body and work and movement therapies, association with subscapularis trigger pain and frozen shoulders. They show a very high correlation. Because the capsule has a very close association with the subscapularis. You could see in this, which has been a photomicrography, and there's a meson trichome dye being used. You could see the subscapularis, and then you could see the articular capsule, how closely they are associated. So once subscapularis is in dysfunction, it will create some more adhesions in the capsule and lead to adhesive capsulitis. So we have seen wonderful results when we have been releasing people who have been deemed as frozen shoulder people by just releasing the subscapularis muscle. One little more thing which I would like to add up before I go more practical is victim versus convict. This gentleman has a tight pants. The result will not come in the front. He cannot put the pants up there. The results will come somewhere else. So we always treat the tissues as physiotherapists which are giving us trouble. Most of the times, it's the tissues which are culprits, not the victims, which needs treatment. If you have a tight tissue in the front, that will create some kind of breakage from the behind. So you have to break the tight tissues in the front, release them, not the tissues which are broken down. Of course, you can use class 4 lasers and matrices to heal them up. Another example is for a mid-scapular pain, the rhomboids giving a lot of dysfunction. I always treat spectrals, not the rhomboids. I leave them. I rather put them on strengthening protocol. Because the moment you will release them in the front, the stress on them will be relieved and the patient will become better. Another example in cervical shoulder area, levator scapulae. I'm going to show you, many of you will be believing that the trapezius is tight. I'll show you that many of them will have actually the levator, not the trapezius today. And why this? Because if you have the biggest pandemic on this earth, the biggest pandemic is not coronavirus. It's forward head posture. All thanks to the Ambanis, we're getting more and more patients because of that, and more people having forward head posture. So once you have that, your SCM and your splenic, they become over tight. And to prevent the head from translating forward, your levator scapulae, which is a rescuer, gets into overactivity because it wants to prevent the head from translating further forward. So you release the levator scapulae when you have a trigger there, like this. You won't get a permanent result. Patient will feel better. 2 days later, he comes back with the same problem. So you need to release the muscles which are the cause, the splenic and the SCM. Automatically, that becomes better. And how do we release this? We release on working on between the different layers of the deep fascia. Earlier, it was believed that there's only superficial fascia and deep fascia. Now we know that the deep fascia is divided into various layers. And very important are the aponeurotic and the epimesial fascia. Epimesia is just outside the muscle. And aponeurotic is the one which is just like you have the peritoneum cavities, you have all those things. In muscular system also, you have double layer system. The one is on the top is the aponeurotic layer, and the second at the bottom is the epimesial. So if you have to have a good movement, your top ones on aponeurotic fascia should glide on the low ones, that is the epimesial fascia. So once there's are adhesions, there's hyaluronic acid becoming thicker and tighter, this movement will be lost. And we need to restore this movement back to make the tissue more and more functional. One last thing before I go for the 10 to 15 minutes hands-on demonstration. Once we release this tissue, are these things permanent? Answer is yes, and answer is no. Now what's this, why I put a jeans out here? This is Levi's lifetime wash-free jeans. I wish when I was in college I could have got that. I was a real poor person washing my clothes. I'll put them in water for 10 days and then take them out. That was my culture of being in the hostel. So this is lifetime wash-free jeans. So if you release the tissue, you don't are permanently better because our day-to-day faulty recruitments will bring them back. So if we don't change that lifestyle patterns, it will keep on coming back. It's like this. If you have these jeans, you need not to wash them if you're in this kind of environment. But I'm sure you cannot manage to not to wash them if you are in this kind of environment. So it's either change your lifestyle or keep getting those problems again and again. For example, my thoracic extensibility affects my glenohumeral extensibility. If I'm in a perfect posture, I won't have any glenohumeral restriction. The moment I start flexing more at my thoracic spine, it will reduce my ability to have the full range of shoulder abduction and flexion. So I have to reverse that. And that's what we are trying to do with myokinetics, trying to add life to years, not to just add years to life. So this was a little presentation of what I'm going to demonstrate here. These are my contact details. If anybody would like to get some information more on myokinetics, you're most free to have that. Now, I'll request 2-3 people who feel that trapezius has been giving them trouble, any physios or any coaches, because physios can understand better. If they have some aches and pains here constantly troubling them, they could come out here, because I have to hunt for one who actually has a trapezius problem. Yes, sir, you're most welcome. One. But I need 3 or 4 people, not one only. Yes. You also have? Come. Any 2-3 people. Come. Right. I don't need to ask you right or the left, but I need to verify whether it's trapezius or it is, say, levator scapulae or splinter cervicis. So I need to do a very unorthodox method of examining you. Right. No, we can't put that. Sorry. At the moment, he's just like a normal patient. He may be one of well-known doctors, but he has to be like a patient. So you have to lie in a prone position with the shoes on. Hands behind, down there. This is a very unconventional, very unorthodox method, but I'll show you that definitely it works. You have to keep your head straight. Take it to the left now. To the left. Take it to the right. Before doing it, he has a little misalignment from here. Wherever it hurts, let me know. Is it hurting somewhere here? Right. Can you sit for me for a second? Sit. Yes, just for a few seconds. Anyway, you have to just sit. Let me keep on holding you. Keep your feet down there. That's it. Just turn around. Just turn around. That's it. Yeah. So this was what was hurting you? Yeah. Right. Wonderful. So you need to do a passive rotation of your neck to the right side. When I ask you, just give it a second. Now take it to the right. Take it to the right. If it hurts you, let me know. Too much. It shouldn't hurt you much.
My tenderness on the side of the trapezius.
Yes. The point I'm pressing, you get some tenderness. Apart from tenderness, I hope you're not getting any pain.
No.
Perfect.
So this examining or you're using it?
No, sorry. I'm just there was a little rotation in your vertebra before going to your muscle. I was just trying to change the proprioceptive input. So you again have to lie back the way you were lying. Great. So now you can keep your right hand on your neck. Wonderful. Take it down. Your left hand on your neck. Wonderful, sir. So you could just sit and I'll show you something. You may not be the right model which I'm going to treat, but I'll show you something where actually your pain is coming from. Can you have this a little opened up? Good. So you're getting some pain here. So anybody would like to come here with to just be a witness to what I'm doing? Anybody? Who can understand, who knows the muscles very well? So if you see where my hand is it on trapezius? No. It is in front of trapezius. Is it? It is on levator scapulae. So with my little assessment, he, being a doctor, see, that's what happens to me. We all understand trapezius is like wife and husband. You understand the relationship between wife and husband? Anything you do wrong, if you're a husband, wife will blame everything for that. One day, my dog got up on the table, ate the pastries, and my wife never said my daughter would have done it. He said, my husband has eaten that. So trapezius is like that. So everybody who has some pain here, we believe it is trapezius. So Doc Sahab, this is your trapezius, but if I press it here, this is where you're getting the pain. So that's the levator scapulae muscle. For him, it is troubling him. So I'll do something for you, but a little later if you want. But I want somebody with the trapezius because I have a very different way. Yes, thank you. You could be here, sir, with us if you don't mind. I'll make you feel, if he's actually having some trapezius, I'll just make you feel his muscle and your muscle. Lie down. Prone. Slippers on, slippers on. I'll wash my hands, don't worry. With the back strap. With the back strap, slippers on. This is a facial system. It was taught by a doctor in USA called A.T. Still. He was a physician, but he lost his 3 sons because of meningitis. So he started thinking out of the box. Good. Turn your neck to the left. Left is this side, my dear friend. Thank you. Physicians know anatomy better than the left and the right side. Good. So, any pain or dysfunction here, let me know. It's hurting? Yeah, sit for a second. This is just a prerequisite. I need to align the bones before I look at the muscles. This is a mulligan technique. I'm not carrying other devices and I'm not having time to screen for manipulation. Otherwise, I would have done an adjusting system or maybe a quick manipulation to get the bone well aligned. Wonderful. Lie down for me. Prone. Come down a little bit. Come down a little bit, little bit. Keep your right hand on your neck. Right hand on your neck without moving your neck. Keep your right hand on your neck. Good. Take it down once again. I think we found the right person. Again. Perfect. Now, sit. Sit for me. So getting some pain in the right side, trapezius, or left is more? Here.
Now the pain is here.
That's a little tenderness, but normally where you get?
It alternates.
Alternate, but right gives you trouble. You feel heavy, which, yeah, right is more. Now, this is giving you pain? Yes? This causes you. So, if you can come here, you can take your shirt down. So, this is what is troubling you? So, this is exactly on the trapezius fibers, if you could see. Yours was in here.
Right, got it.
So, your levator scapulae, and in a little research which we made at our universities, when you keep your hands in front of the body and you use laptops, these things, trapezius gets more into trouble. But by virtue of using the phones and your thumbs, you get more of levator scapular dysfunctions these times. So I'll share a few things with you to make that better a little later. But I need your job is not done. Thank you. So that was a quick differential diagnosis. Without a scan, I could do that, finding the difference between the trapezius and the levator scapulae. So you're getting some pain there. Right. Now, I'll work on a very different system of releasing that fascia. Lie down supine or prone, whatever you're comfortable. Now without shoes. You can sense your own tightness. You can sense on your, you need to, because after that you have to tell me whether it's become better or not. So keep your hand, see for the tenderness and the tightness. Appreciate that, because you will be my biggest witness. You can feel the tightness? Great. So you'll get some pain here. Let me know when it gives you pain. It's giving you a lot of pain? Yeah. It will not give you pain here. Not here. And this is not acupuncture. This is the facial kinetic change which we are talking about.
Sir, the time is up, sir. Can you make it?
Sorry?
The time is over.
Sir, just 1 minute, if you permit me.
Yeah.
Just 1 minute. It's almost done. You're getting pain here? Exactly here? So you may get a lot of pain for split seconds. But just split seconds. Done. My job is done. Hands down. Take your right hand on your neck now. Great. Take it down. Sit. Now check your trapezius.
I have the cord since a long time, lots of years. Maybe that's why I can still feel the cord.
You feel better? Relaxed? I'll make you feel. So don't appreciate here. Now just feel the change here. Is it the same tight? How much tenderness you're getting? No tenderness? And feel the relaxation. Just try to move it left to right and right to left. What you're feeling? Yep. So, you didn't have pain probably.
I didn't have pain. Right?
So then why did you walk in here?
Because I had trapezius tightness
Okay.
since a long time. So I thought I would be the perfect patient because I have tried trapezius.
Right. So you can feel no tenderness anymore, which was there. Yeah. Thank you.
Thank you. Thanks a lot, sir.
Thank you,
Fantastic
sir.
demonstration. Thanks a lot for this valuable time spent. I think we have had a very interesting academic session in the morning. It's time to take a break, enjoy the lunch, and regroup at